And one of the things that is really important in caring for a burn patient is a team approach. And it really hinges on many different members of the team, from the nurse to the therapists to the pediatricians to the anesthetists, to really get a good outcome for a burn patient, especially a major one. I thought I would start by introducing myself. I'm a general surgeon by specialist qualification and um, trained in Maritzburg since 2006 and was the one to start a burn service. Previously, the burn patients used to be managed by whoever was on call, so whichever team in Edendale, it was either the breast team or the GI team, and they got lumped with the burns. And then in Grays, it was a little bit different. Burns used to be looked after by plastic surgery until 2016 when we took it over and we became more a metropolitan burn service. I have spent some time in ICU, a number of years in Maritzburg, both Edendale and Grays, as one of the ICU consultants. I got permission to go and spend 3 months in Red Cross ICU as well, particularly because that really is, Prof. Roeder was the pediatric surgeon in Cape Town, who was the father of burns in the country. And his intensivist, Andrew Argent, they've looked after a lot of sick babies, and I learned a lot of very valuable things in my time there. And then I did a brief fellowship in a burn unit overseas. And Shelley Wall and I are the only 2 surgeons in the country that only do burns. All the other even the burn units will be headed up by a pediatric or trauma or general or plastic surgeon who will only do burns part-time. So that's something quite unique in Maritzburg that we've created, and I think it goes a long way to changing outcomes. Today we're going to talk about a range of things, from pathophysiology through fluid resus and inhalation injury, a bit on electrolytes, a lot on sepsis and surgical principles, a little bit of transfusion, and then of course pain, and then I'll end with prognosis. So your skin is the largest organ in the body and responsible for fluid homeostasis, thermoregulation, and probably one of the most important ones being the barrier to infection, and then a number of other functions like immunological, neurosensory, and metabolic. And an injury to that organ causes changes throughout the body, characterized by profound immune compromise, a profound hypermetabolic stress response with the excessive protein catabolism, and that's leading to SIRS, severe sepsis, and multi-organ dysfunction. And all of the problems that we see in these burn-injured children are linked primarily to those 3 components: the immune compromise, that profound metabolic response, and protein catabolism. And also that those problems are not resolved until the burn itself is resolved. And by resolved, you'll see we'll talk about that implies either healing or skin grafting. I'm going to start with inhalation injury. I think it's not generally well understood, and it has huge implications, particularly for need for ventilation and ICU, and as well as prognosis. And it's divided into the anatomical divisions of above the larynx and below the larynx. Generally, the more common injury is edema of the larynx secondary to hot air. And this would be a patient that is trapped in an enclosed space, burning flames, where that air is hot, damaging that upper respiratory mucosa. If there's much longer exposure, for example, smoke, hot particles, irritant gases, that's then the progression of the injury to the trachea and then into the bronchi and into the lung tissue itself. And depending on where the injury is, that determines what clinical picture you're going to see. And if it's just that upper airway that's injured, it's typically laryngeal obstruction, and you need, intubation to maintain that airway, maybe some bronchospasm, and that typically resolves over a few days. And that has a good prognosis, as opposed to lower lung injuries where you see sloughing of the mucosa. Obviously, that the mucosa is damaged, the mechanisms to manage infection are damaged, and you see pneumonia, you see plugging, collapse, consolidation, still bronchospasm, and then progressing onto, pulmonary edema and ADRS. And those patients need often prolonged ventilation, much more specific therapies. And these are the injuries where, in the classic description of prognostic tools, inhalation injury carries a great weight and is a big factor for poorer outcome. But this really is the more severe injury below the larynx. What you don't see on this picture is hot water. And another common misconception, that sort of hot water burns to the face and neck can cause inhalation injury, and that's just not true. There may be external edema, particularly if it's a burn to the neck, causing airway compromise, but that is not inhalation injury. Again, you may get swelling of the face, you may get swelling of the lips, even the tongue. That very rarely causes airway obstruction. And again, it's definitely not inhalation injury, and that usually settles down quite quickly. The one, though, that we've never, in my 15 years of managing burns in Pietermaritzburg, have I ever seen a hot steam burn, until many of you know our one particular very special patient. So hot steam is obviously a significant injury, and in our setting previously quite rare. Hansi, for instance, says now with COVID in private practice, he has seen some hot steam injuries in children with burns. So that's something to be aware of. But the history must be hot steam or this classic enclosed burning flames, and not hot water. Then moving on to the circulation and the need for fluid resuscitation is really linked to the presence of burn shock, which is typically present in burns more than 15 to 20%. And there's a number of components that lead to this specific entity of burn shock. And it's both relative and absolute hypovolemia. So you've got relative because of the inflammatory process and the vasodilation, but you've got absolute hypovolemia because of the loss of fluid from the intravascular space into the interstitial tissues, and that's fairly classic, and it's the natural history that a burn patient will have some swelling and edema away from the site of burn. It's completely normal, and I almost want to say, if you have a significant burn, sort of more than 20 or 30%, if you're not seeing edema on day, sort of the end of day 1 and 2, the patient's probably under-resuscitated. And then, of course, the other absolute loss is through the wound exudate, and that open skin and loss of the barrier. The lesser known component is cardiogenic dysfunction. So the burn injury itself causes some suppression of the heart, and that's the last component of burn shock. So we know we need to fluid resuscitate burn patients because of this. There are many different formulas, and they're really only a guideline. It's less important which formula you use. It's more important that you adjust that fluid rate according to urine outputs, and that obviously monitoring that response is essential. And it's not a case of typically, what I teach the surgeons is, so you write up your formula, you send the patient to the ward, and you never see them again, well, because the formula is running. The formula is a guide. It may be enough for this patient, it may be too much for the next patient, or too little for the next. And you have to go back and review the patient. And I think another important underappreciated component of resus is that over-resuscitation is as bad as under-resuscitation. And just a brief moment, I wanted to show you, this is a picture showing sort of the historic progression, but just how many different formulas there are available. And they really are quite varied, with components of crystalloid resuscitation, and initially then inclusion of colloids, which fell out of favor. And it seems that colloids may be making a comeback to burn resuscitation. But just it's interesting that there's a huge number of formulas available. I think in our setting, crystalloid is still the simplest, the most cost-effective way to resuscitate a burn patient, and I would not be promoting the use of colloids for acute resuscitation except in exceptional circumstances. And really this would be the very large total body surface area burns, where colloids can be useful to decrease that total resuscitation volume. And in our setting, we're not managing those patients expectantly. Those are the patients that we are palliating because of their overall prognosis in our setting. So I think colloids don't really have a role in our setting yet. It might be silly to mention, if we're resuscitating a patient, you must insert a urinary catheter. You'll be amazed at how many doctors refer patients to me. They've started resus, and when I ask them about the urine output, they say, but they haven't inserted a catheter. It's really the most useful and simple tool to manage the resuscitation, obviously along with clinical examination, heart rate, capillary refill, blood pressure, GCS, and that we don't use blood gases or more invasive monitors in that first 24-hour period. We know there's going to be a significant metabolic acidosis, and we know the acidosis will be proportional to the size of the burn. I find using a gas to resuscitate often makes people too aggressive, and they're used to either an acutely septic patient or a trauma patient where you want to restore that volume over the next few hours. The burn patient is different because of the pathophysiology. It's that slow, constant leak. It's the loss through the skin. It's the, cardiac suppression. It's the loss into the interstitium. So there's ongoing leak, and that's why the formulas are over the first 24 and 48 hours, because it's a slow, ongoing resuscitation rather than a quick one. So blood gases I don't find are useful in that acute stage. Obviously further down the line, particularly in sepsis, they're absolutely essential. And then our guide for fluid resus, you want to increase the fluid rate if you're passing less than half a mol per kg per hour of urine, and you want to decrease that fluid rate if you're passing more than 1 mol per kg per hour of urine. And that's as important, to decrease that rate. And I think we're reluctant to. We think, fluid resuscitation is going well, the patient's passing lots of urine, we'll leave it running. But you shouldn't. It needs to be turned down, because the consequences of over-resuscitation are burn depth conversion, pulmonary edema, cardiogenic shock, versus the acute kidney injury and persistent burn shock if we under-resuscitate the patient, which I think is a lot less common actually. And we need to think about turning down that rate to achieve the target urine output. Moving on to electrolytes and minerals, that hypermetabolic response causes a derangement in a number of endocrine systems, and typically our patients will be in a hypocalcemic, hypoparathyroid state. They've got high urinary excretion despite the hypocalcemic state. There's distorted bone homeostasis and reduced parathyroid hormone levels for the level of calcium. Sort of can't separate all these electrolytes together, so it comes with a hypophosphatemia. There's tissue phosphate depletion and increased intracellular utilization, as well as losses through the kidneys and the exudate. Same goes for hypomagnesemia. Wound losses, intestinal losses. There's increased uptake due to increased needs into the cells, as well as increased losses. And really, it's important that these are measured and replaced. Many times people will do bloods on burn patients and just do your classic, FBC, UNE, and maybe liver functions. It's really important in the major burns to also do your CMP and replace those levels if they are low intravenously. The oral replacements just aren't adequate. And then, of course, we've got other problems with vitamin D, zinc, and copper deficiencies. Zinc, we do have capacity to replace it. The problem is our vitamin D and copper deficiencies, although they're well described in burns, there's just no access to replacement in our state setting, but I thought it was worth a mention. And then leading on from all these electrolyte metabolic issues, I thought it's interesting to talk about the more academic and advanced therapeutic options, although I've highlighted the ones that really we have access to. And that is the early enteral feeding and your protein requirements of 2, but in children it's 3 grams per kg per day, and of course involvement of the physio, and we should be introducing a resistance exercise program. These other components, so oxandrolone, anabolic steroid, has shown significant improvements in lean mass gain, especially when combined with a resistance program, and their bone content and density improving sooner and providing longer lasting benefits. So oxandrolone is not, unfortunately, available. It's an oral tablet, but not available for us, although I think that would be extremely beneficial. The other component is beta blocker, propranolol, positively affecting the metabolic rate, cardiac and liver function, as well as the musculoskeletal system. The problem with propranolol is the complications, and because it's obviously going to influence that heart rate, and the heart rate for us is one of the most sensitive signs for picking up that there's other problems, unless you're working in a very advanced sort of burn ICU or a very mature burn ICU setting, propranolol can cause more complications than worth. And Red Cross, our reference again, they have tried the use of propranolol with absolutely disastrous consequences. So I'm not by any means proposing that we introduce this, but I thought it's interesting from an academic point of view to understand that propranolol is used in other parts of the world as part of management of this hypermetabolic response. And then, of course, for your bone complications, potentially bisphosphonate therapy can have a role. It's not widely used and there's not enough evidence to guide its use, but it is there in theory. Similarly, the use of insulin to both modulate the hypoglycemia that we see in major burn injuries and sepsis can also influence the increase of protein synthesis and result in positive net balance as well as an anabolic effect on bone. Again, in our setting, I think it's difficult because the complications outweigh the benefits, where, hypoglycemia is going to cause a lot more problems, and I don't think we're quite there yet. but it is something to think about, and potentially in an ICU setting, something that we could talk about introducing. Which of course brings us to sepsis, the perpetual enemy for the burn patient. And it's a difficult diagnosis to make because SIRS looks a lot like sepsis, which looks a lot like that hypermetabolic response, which presents to us a patient with an ongoing tachycardia and that, I've put it in inverted commas, that low-grade fever. Because fever in a burn patient is quite specific, that hypermetabolic response means that the hypothalamus resets the core temperature of the patient, and that normal fever of 38 or pyrexia of 38 in every other patient is not appropriate in a burn patient. And more, you've got to see it in combination with other things, or when you're getting above 38.5 is when we would start to be more concerned about it being a sign of sepsis in a burn patient. So it's important to understand the baseline vitals for each patient and what their baseline tachycardia for their burn injury is. And really what you're looking for is a change higher than their normal baseline. For me, any GI dysfunction is absolutely pathognomonic of sepsis in a child with burns until proven otherwise. The mechanism is that it's a septic ileus. Probably the most common sign is diarrhea, and I really want to impress upon you that if you see diarrhea in a child with burns, it is sepsis and it is not acute gastroenteritis. And I see many times by sort of all people managing burns, pediatricians, surgeons, the sort of assessment in the notes of a patient with diarrhea is acute gastro. It's not. Question is, why does it matter? Why do we make such a big hullabaloo about it? Well, the treatment is different. The way gastro is treated, you need to manage their losses, but you're not looking and managing a source of sepsis, which is so critical in the burn patient. Also, I think your fluid resuscitation would be different in acute GE as opposed to the burn patient. We would resuscitate with Ringer's lactate, and depending on their sugar levels, that may or may not contain dextrose. But really, we're going to be investigating sepsis, looking for a source, and almost always starting antibiotics. So it's critical to understand the difference because the management is different. And then, of course, the other component of sepsis that I think is largely missed, mostly by the surgical guys, is a low white cell. Everybody's looking for that high white cell, and that low white cell is missed. And in my experience, those children that develop that early drop in white cells, often it's a marker of a poorer prognosis or a sicker patient, a prolonged sepsis and hospital stay. And it's one of the things that we should be worried about and definitely initiate treatment. What I wanted to spend some time on now is the idea of source control, because obviously that is absolutely critical. If we're saying or we're making the diagnosis of sepsis, we must gain source control for our other components of management to be successful. And if I give you a minute to look at each of these pictures and ask you to think about which of these ones you would think needs to go to theater where source control is a problem. Because obviously that's a multidisciplinary team here involved, and depending on where you're working, how aggressive you need to get with the surgical department taking them for debridement. So this top left here, that's a typical hot water scald. That's a superficial partial burn. And while the skin barrier is lost, and yes, that open skin per se is definitely a source of sepsis, there's nothing to be gained by taking that patient to theatre. It's a superficial partial burn and will heal. There's nothing to operate on that wound. The management is cleaning that wound. You want to decrease the bioburden that's on the wound and on the adjacent skin. And you definitely want to use a topical antimicrobial, antiseptic type dressing. But that's about all you can do. That is definitely not a patient that should go to theatre because there's nothing to debride. Similarly, if we look at this patient here on the right, again, that's an open wound. We're looking at granulation tissue. And yes, while we see some thin slough on the surface of that wound, that can be wiped away. And again, a wash and an antiseptic or antimicrobial dressing is going to be the management line if this child was septic. There's nothing to debride here. And taking that patient to theatre would serve little purpose unless it was to close the wound and do a skin graft. But if the child was so sick from sepsis, you might have to balance, well, the outcome of an invasive surgical procedure where you're harvesting donor site at that particular point in time. So I would argue these two definitely don't need to go to theatre. Yes, that might be the source of sepsis, nothing to be gained from theatre. Versus these two in the bottom. Now this is a mixed depth burn. Here you see the wound is starting to heal, but here you see a little bit sort of areas of thicker slough, non-viable tissue or eschar. Again, the wound is always potentially a source of sepsis. And yes, this non-viable tissue here will hold bioburden, will hold bacteria because of the presence of dead tissue. And you could argue this patient could benefit from this debridement. It would be quite a small debridement. It's quite dry, it doesn't look bad, and I would think maybe it's the source of sepsis, maybe it isn't. I'd be worried about other sources and looking for pneumonia, looking for a UTI, which of course is extremely common, but taking this patient to theatre and excising this part here does have potential benefits. This picture here on the bottom right, however, that is the classic picture where source control needs to happen. That burn is deep, it looks mottled, it looks like it's becoming invasively infected, and that's the patient where I think it's imperative to offer a reasonable period of resuscitation, but really it's a priority to get this patient to theatre and excise that necrosis. That for me is the source of sepsis in this patient. But really just to press home, and there was an unfortunate incident in another hospital in KZN. This baby had 15% hot water burns, developed severe sepsis, and sort of a combination of factors led the child to be taken to theatre for source control, in inverted commas. Unfortunately, that baby arrested immediately after induction. Secondary, obviously, to the sepsis and poor resuscitation, and has subsequent sort of limb necrosis and hypoxic ischemic encephalopathy, which I think is tragic because the child didn't need an operation. And I think it's a really important component for sort of intensivists managing these burn patients, and definitely the surgeons managing these patients, to understand when surgery is indicated. Of course, one of the other issues around source control, which I think is a common problem, is that central line. And we see this not uncommonly, We've got to really spend a lot of time fixing that CVP down. It's obviously it's an invasive procedure. We need the line, but we don't want to come and find this an exposed line. This obviously needs to come out, and we've got to try and prevent this. I think this is a real common problem, and we've got to try and look after those lines. A brief word on antimicrobial use in burns. So there's definitely no role for prophylactic antibiotics. There's absolutely no benefit in the literature on this. And really what we would do by using it is selecting out resistant bacteria. So that's a no-no. We want to treat systemic sepsis with antibiotics and not wound sepsis. Again, a common misconception by the surgeons is maybe a delayed presentation. Patient comes to the clinic or to the emergency department with a grotty looking and smelling wound. That is not an indication for antibiotics. You need to clean it up and look for signs of systemic sepsis. Otherwise, the management really is topical wound management. Unless, as I say, there's signs of systemic sepsis. And then what antimicrobials are we going to use to cover? So there's the classic description that it's skin commensals are the cause of burn sepsis. Yes, this is true, but only in the first 48 hours. So in early burn sepsis, where your likely organisms are staph and strep, and this is what we would call toxic shock. And the treatment is with a penicillin as well as clindamycin, and you need the clindamycin because it's a protein synthesis inhibitor to stop the production of the proteins or the toxins. And that's really that first 48 hours. Sepsis in the burn patient after 48 hours is generally nosocomial sepsis, so you must have pseudomonal cover, and the commensals are not coming from your skin at this point in time. They would be coming from your gastrointestinal tract or your respiratory tract. So you must have gram-negative cover. So obviously Augmentin is not appropriate at this point in time unless the patient is coming with severe sepsis and they're coming from home. But if they've been in a hospital, piperacillin tazobactam with or without amikacin would be that first line cover. And just a word on having a low threshold for antifungal cover, not really in that first episode of sepsis, but in subsequent episodes. So our patients are very high risk for fungal infections, especially if they've had that initial exposure to broad spectrum antibiotics, but they've lost their skin barrier, and obviously they're full of invasive lines and a catheter. So just to put sort of the need for antifungal cover higher up in your mind if we're on second line antibiotics. Just some words on surgical principles. So partial thickness wounds heal through epithelialization. I've mentioned previously we want to keep that wound clean and we want to use topical antimicrobial agents as dressings, but there's no need for surgery. The deep wounds are the ones that require closure through surgical intervention. And there's two approaches. There's the conservative approach where we wait for spontaneous eschar separation and we graft the subsequent granulation bed. This promotes maximal preservation of any viable tissue. Of course, it's understandable that the problem is it's a much higher risk of infection, electrolyte disturbances, as long as the prolonged inflammation, hypertrophic scarring in this line of management. The more contemporary approach would be excision of that eschar and closure, as you see demonstrated here. That's where we've excised all of that non-viable tissue and you're left with a healthy bed. This reduces the infectious complications and the length of hospital stay. It's one of the key components to reduce the protein catabolism, the immunosuppression, and of course the evaporative and electrolyte losses. The challenges in our setting are access to theatre time, It's obviously a massive insult because not only are you doing a big operation, but then you need to harvest donor sites. So the need for post-op organ support in these larger burn injuries is one of the components that is not always readily available in resource-limited settings like us. So how do we decide on the timing of the surgery? And it depends on a number of issues. Certainly the physiology of the patient. Some patients are really quite brittle and tolerate only small procedures, so we must do many small procedures. Some patients we know that they always have a massive inflammatory response and will need organ support post-op, versus other patients who are really quite robust and we do major surgery and they never need ICU and post-op organ support. It's also the nature of the burn wound, and here this is a picture to demonstrate this eschar is nice and dry. If the patient's well, that eschar's dry. This is not if I've got to manage a very, one list a week. If I've got many patients to decide who goes, this would be a patient I think could probably wait. While I know obviously technically all patients should go, it's just not possible. And this is one of the patients that could wait because that eschar's nice and dry and we can peel it off and then do a lesser procedure. Surgical skill is obviously another component, and if I show you here these two pictures, this middle picture here demonstrates an inadequate debridement, and that, taking this patient to theatre, giving them a big operation and a big anesthetic, but they're not actually doing the job, serves no purpose. And this is the type of debridement that we're looking for. And then obviously, anesthetic skill is really important in this component as well. It doesn't matter how good the surgeon is if you don't have the anesthetist who's matched in expertise to manage small, sick babies. Obviously, the availability and access to post-op support is also key to deciding on when we take patients to theatre. And lastly, as I've mentioned, the nature of the burn wound. And this is in direct contrast to this first picture here. This is someone I would say, this needs to go to theatre. That burn wound is not looking good. That needs source control. And obviously linked to surgery, but also a huge component is anemia of thermal injury. And yes, while we lose a lot of blood in theatre, also the anemia of critical illness is one of the factors in burn-injured patients. It's poorly understood, but we know that it's linked to bone marrow dysfunction and the ongoing inflammatory state. Just a word that anemia does not impair wound healing and only affects hemodynamics and oxygen delivery when quite low. And we must balance the need for transfusions against transfusion complications. So what do we do to manage anemia in the burn patient? I thought I'd mention EPO. It has not been found to be beneficial to burn patients or critically ill patients and does not augment erythropoiesis to the point of decreasing transfusion rates, so it would not be indicated. And for surgery, we're looking at blood conservation techniques. So CLASIS is the sub-burn injection of a fluid that contains an anesthetic as well as adrenaline, and this can be significant in reducing its intraoperative blood loss. We can use tourniquet when limbs are involved, but more typically we would be using topical adrenaline with compression and elevation. And then just that a restrictive transfusion strategy is safe and beneficial in both adults and children, and there's lots of literature in burn patients to support a restrictive strategy. There's certainly a number of years ago there was this misconception amongst surgeons that burn patients needed a much higher transfusion threshold, and they were trying to keep HBs around 10. That's just not true. And as in other critically ill patients, we transfuse when the HB is below 7. And obviously there's exceptions to the rule that we break, but in general, we are following a restrictive transfusion strategy in burns. And then, of course, pain is a very big component and something that is close to my heart. And those of you that have worked with me know that I get quite irate and upset about it. But this picture really gets right into your heart, and we've really got to take this away. We can't save everybody, but we can take away their pain. And just a bit of physiology. So obviously the stimulation of the skin receptors through to heat, mechanical distortion, as well as chemical stimuli, those are all disrupted due to the thermal injury. And although in a full thickness burn we say that the entirely destroyed nerve endings will not transmit pain, surrounding that full thickness burn, certainly in a partial thickness burn, and as you generate new granulation tissue, there are exposed nerve endings which will generate pain throughout the time and course of treatment. And we see this primary hyperalgesia and the secondary hyperalgesia, where the inflammatory mediators sensitize those nerve endings at the site of injury, and it's both at the wound and the immediately adjacent skin. And they're very sensitive to mechanical stimuli, which is exactly the dressing change, plus or minus the debriding, sometimes the agents we use for the dressing. And then, of course, because it's an ongoing dressing change and sometimes ongoing surgery, it's that continuous and repeated peripheral stimulation that lead to increased sensitivity, even in the unburned areas. As I said, typically as a result of the dressing changes and the repeated surgery. And then we can add a component of the occupational and physical therapy as well. And the burn pain is divided into procedural pain, which is that high intensity pain at the time of dressing or surgery, the resting pain or background pain that is just ongoing because you've got exposed nerve endings. And then if your background pain is inadequate, that's when you get the breakthrough pain. And then just some of the other components is this chronic exposure, certainly the big burns, the burns that have been with us for a long period of time, often have neuropathic pain, and we need different modalities of treatment. We need to consider anxiety as a component in these patients, and certainly depression, I think, is something also unaddressed. And just if you think about this kitty here, this is a 2-year-old with 45% total body thickness area burns. Both arms, the full tummy and chest and the full back is burnt. That's almost half her entire body is open wound. If you just think to your own wound, whether you've had a surgery or a roasty, you know how sore that is. Now imagine expanding that to half your body. And really these sort of burn patients are different to the other surgical patients that are managed in an ICU who often have had surgery, but they've then got a closed wound or a sort of a surgical site, and definitely different to the medical patients who have none of these open wounds. So they really are quite different, and their demands are quite high. Not to forget that hypermetabolic response means that the pharmacodynamics and kinetics are all deranged in these patients. So it's dynamic. The needs change from the acute injury as you start healing, or the acute injury, then you have a debridement, your pain will go up. Then we put a skin substitute on you, then maybe your pain's going to start getting better. But when we take you back to theatre to harvest your donor sites, your pain's going to be worse again. And donor site pain is really quite significant. So we need to be dynamic. Their needs are not the same throughout the course of their stay. And it's a stepwise approach. We start with the basics like paracetamol and Tilidine, and then we keep on adding until we achieve adequate analgesia. Certainly multimodal analgesia is, I think, really the standard of care nowadays, and we are using a multitude of different drugs, which we know is useful. I thought I'd just mention, PCA, patient-controlled anesthesia, probably not that applicable in the ventilated patient in a pediatric ICU, but I think it can have its place in the older child in a general ward for post-op pain. And then obviously ketamine is really the mainstay of what we use for procedural and even sometimes difficult to treat background pain. And then lastly, to end on prognosis, which is always a difficult topic to talk about, just sort of a couple of papers, and sort of one of the premier burn units in the world published a paper in 2000 actually, where their mortality for children in burns 0 to 39% was 0%. Even in children with burns 40 to 59%, their mortality was 0%. And only when the burns were 60 to 100 did they have a 14% mortality. And that was back in 2000. And I've put that up there just not because it's realistic for us by any means, but just because it provides interesting concept or interesting context. And if you're not doing burns every day, you don't know what remarkable things can be achieved with resources. And then in the Lancet, a few years later, another very prominent burn unit published a paper, and I've just put the conclusion up here, is that we show prospectively that mortality in severely burnt children cannot be reliably predicted on the basis of demographic and injury characteristics alone. These data suggest that all severely burnt children should be given a course of treatment before consideration of treatment futility, which again is up there for context. It's difficult to predict mortality, and out of the sort of lower middle income countries, the pediatric bowel score has come to the fore, where they look at, so age is beneficial. In the adult patient, age is detrimental, and the older you get, the worse your bowel score and the worse your mortality. But in children, it's beneficial. So this is total body surface area. Subtract age, and then plus 18 times R, where R is 1 if your patient has inhalation injury, and obviously 0 if it doesn't. So you see your factors there really predicting mortality are total body surface area and real inhalation injury. As I started the talk, we talked about that inhalation injury below the larynx, and that's the inhalation injury we were talking about. We're not talking about a bit of upper airway edema. So where does that leave us really with making local decisions on prognosis? Now, in my opinion, and in my 15 years of looking after burn children in Pietermaritzburg, I would say that 50% is probably the absolute cutoff for us. Above that, the burn is so massive and the derangements so great, we definitely don't have capacity. We would need isolation. We would lack donor sites. We don't have access to the gold standard substitute, which is cadaver skin, and I think that's just not possible for us. Less than 30%, I think we should definitely be going balls to the wall for. And I think even up to 40%, I think we've got a good enough system to not make the limit there. I think our more difficult decision-making group is the group between 40 and 50% total body surface area. And here it would be dependent on the age of the patient. So the very young, I think, don't do well. So sort of less than 6 months, donor sites are also a big issue. And I think the older child, where, they can behave more like an adult, could be difficult. It would depend on, is the burn partial thickness versus deep. If you've got a 5-year-old with 50% superficial hot water burns, I think that's worth trying, because their need for surgery is obviously not there. You may get some areas that convert, but largely that will heal with the right systemic care. And then the area is burned. So for example, if there's many donor sites accessible, but typically the legs and arms and back are donor sites. So if all of those are burnt, and really you're left with, example, an abdomen, chest, and maybe the head, that makes things just technically more challenging without the sort of, again, the surgical components of cadaver skin to help us get through that. So depending on the site of the burn, and then unfortunately also depending on the season. If we have a ward in an ICU in the middle of winter full of other sick babies and big burns, a child with a borderline burn, we don't have any more capacity left, and we should offer prognosis, we should offer palliation, versus in the middle of summer, we maybe don't have any other big burns, and then I think it's worth investing some resources. Generally, inhalation injury in our setting is rare, so it does happen, but it's not a common sort of component in the decision for prognosis. As I mentioned, it would depend on the grade of that inhalation injury, upper versus lower, as well as being how much of the total body surface area is burnt. If you've got a really severe lower inhalation injury in combination with a large TBSA, I think we should palliate those patients versus a 10 or 15% cutaneous burn with an inhalation injury. I think that's much more manageable. So just to end off, and unfortunately, because you don't, see the patient in the clinic, you look after them when they're very sick, and you see all the ones that do poorly and don't survive, you don't see the ones that do really well. And I think it's probably the difference between me and everybody else, and why Monday is my favorite day of the week. It's because I get to see all those babies that we sweated blood and tears over getting through these really sick periods, and that when they've done well and they've survived, that's why we keep on doing it again and again and again. So I thought I would end off with the fact that although we do lose a number of patients, what you don't see is the number of really sick ones that actually survive to go home and do quite well. So there's some references, and